Hi everyone. Today I am going to talk about physical therapy for patients undergoing heart and lung transplants. And I've been involved with the heart and lung transplant programs at Froedtert for many years. And I will say that these are some of my favorite patients to work with. They are the most grateful group you will ever find. And we have so much to offer them in physical therapy to make their quality of life better that it's just really fun to see how well they do. So today we are going to talk about the process of becoming a recipient and then talk about kind of the three phases of organ transplant. So the pre-phase, the early postoperative phase when the patients are in the hospital, and then later postoperative outpatient phases. And we'll talk about how transplant is both similar and different between heart and lung. And then we'll talk about transplant medications and some of their implications for therapy. So I like this quote, which is from one of our lung transplant physicians. Never has so much been done for so few by so many. And it's a twist on a Winston Churchill quote from World War II. But organ transplant requires a huge team, and PT is really a vital part of that team. This is a small number of patients relative to all the care that patients are getting in the United States. But they take up such a large percentage of the resources. And so we are really excited to be a part of such an important venture here. So this is a busy slide, and you do not need to know all these things. But what I want you to know is, first of all, heart and lung transplant are relatively new procedures. The first lung transplants were done in the 1980s, which I know to you guys seems like a long time ago, but not as much to me. So we being the scientific community, are still learning a lot about how to make this work better. Organ transplant is also the most highly regulated area of medicine in the country. And that's because it really needs to be a very transparent process, and people have to have faith that this is a process that is safe and effective in order for the system to work and patients or people to offer to be donors. So UNOS, which is the United Network for Organ Sharing, has what we think of as the list of patients who are listed for a transplant and officially waiting for an organ. So just some statistics. As of very recently, in the United States, there were 3,455 patients waiting for a heart transplant, 976 waiting on a lung transplant, and 39 waiting on a combined heart-lung transplant. Those are very, very rare. So if you look at the box on the right, heart and lung transplants make up a much smaller percentage of organ transplants than, for example, kidneys and livers. So we're talking about a small number of patients overall. If you think of the number of joint replacements or the number of CABGs done in the United States in a year, it's huge. But in an average year, there are only about 2,500 lung transplants done in the country. So it's a very specialized endeavor, only done at a few centers in each state typically. And the average center only does between 10 and 19 transplants in a year. Obviously, there are some centers that are much bigger, do many more, but it's not that common a procedure. And every US center that does transplants has to report their data publicly on the SRTR website. So you're always have the option of going there to look up how places in your area are doing. So this next slide is just my plug for everyone to think about being an organ donor, because the major limitation to organ transplant is increasing demand and a limited supply of donor organs. So unfortunately, many, many people die waiting for an organ in the United States. And one donor can save 8 lives. So if you look at the pink on this slide, it represents the waiting list, which is increasing kind of very, very rapidly as compared to the yellow and the blue, which are the transplants and the donors over time, which are not going up nearly as much as the demand is. So on average, about 20 people in the United States die waiting for some organ transplant. So this is my plug to go to donatelifewisconsin.org and really think about being an organ donor. Hopefully none of us ever have to experience that, but it can be life-saving for someone if it does come up. So how do patients get on the wait list to become an organ recipient? So patients who have end-stage heart or lung disease have to undergo an extensive medical and psychosocial evaluation to see if they're candidates for transplant. And the goal is to place organs in people, first of all, who need them the most, but also who will get the most benefit, because we have a very limited supply of organs. So we want to be sure that patients who get a transplant can make the most of it and can do the best with it. So donors and recipients have to be matched by a number of things. One of them is blood type, so that the chance of rejection is less. The other is size. So if you try to put my heart, for example, into a male who is 6'3" and weighs 220 pounds, it simply won't be big enough to pump enough blood to get to all of his tissues and oxygenate him appropriately. So the recipient and the donor size have to match up within certain parameters. The location of the donor and the recipient are important because organs can only stay out of the body for a certain period of time before they start to deteriorate. So that's called the ischemic time. And for hearts and lungs, the most that they can stay out is 4 to 6 hours. So you have to be within a certain geographic radius in order for your donor and your recipient to be close enough together that the organ can get out of the donor and into the recipient in an amount of time in which the organ will still work. Excuse me. It is longer for other organs, but hearts and lungs have the shortest ischemic time. Patient's medical status matters, and then for some things, time on the wait list. So heart and lung transplant use two different methods to calculate how organs are allocated. Heart transplant uses 6 urgency categories from status 1 to status 6. And so patients who are status 1 most urgently need a heart. And they are generally the sickest patients. They are generally patients who are in the hospital on VA ECMO or on some other biventricular support. And then status 6 are the most stable, if you will, of patients. So organs are allocated first to anyone in status 1 who meets all the other criteria, and then if no one in status 1 meets those, then it goes to status 2, 3, and down the line. Lung transplant uses a completely different system called the LAS, or the Lung Allocation Score. And it's this really complex mathematical formula that includes their diagnosis, their expected survival, and a whole bunch of their health data. So things like their PFT data, and their 6-minute walk test data, and their oxygen levels, and how much oxygen support they require, and lots of other things. And that generates a score. And the higher your LAS score, the higher your priority for an organ. So scores can go up to 100. So all other things like size and blood type matching, someone whose LAS is 95 will get a heart over someone whose LAS is 35. So the unique thing that the LAS does is it takes into account expected survival. So for example, for patients who have COPD, a lung transplant provides a clear quality of life benefit. They are not short of breath all the time in their surviving years. But it doesn't provide a clear survival benefit, meaning they don't necessarily live longer with a lung transplant, but they live better. So therefore, the part about disease that gets plugged into the LAS gives them fewer points for COPD versus a patient who has cystic fibrosis. And those patients are expected to live much longer after a lung transplant, in addition to the quality of life benefit, so they get more points towards their LAS for their diagnosis. Okay, so lots of things to consider when we talk about organ transplant. As I already said, there are many more people waiting than there are organs available. So patients on the wait list can wait for days, and I've seen it happen where someone got on the list and they got lungs 3 days later, which is rare, but happens. And I've seen people wait months to years for their transplants. So that unknown is very difficult for patients, that they could get a life-changing call at any minute or not for any time soon. There's a lot of guilt associated with waiting for an organ transplant because patients know that someone has to die, unfortunately, for them to get a transplant. And so that's a very tough thing for them psychologically. Transplant patients need really good psychological and social support, and their caregivers do too, both before and after transplant. Because transplant centers are so specialized and there aren't many around, for example, in Wisconsin, the only places that do transplants are in the Milwaukee area and in Madison. If you live far away from a center, oftentimes you have to move and live closer to that center while you're waiting and then for a while after your transplant. So if you live in northern Wisconsin or in the UP of Michigan and you're sick enough to need a transplant, and you have to relocate, that's very difficult medically, and that's very difficult in terms of your social support. So these patients need kind of a village around them that helps them get through the pre and post-transplant periods. Okay, so we'll kind of go back and forth between heart and lung for a little bit here. So heart transplants are utilized for class 3 or 4 heart failure that's not responsive to medical management. Commonly seen diagnoses are severe coronary artery disease, cardiomyopathy, valvular heart disease. And I should bring up that this talk is generally about adults needing heart and lung transplants. Obviously, in children, congenital heart disease is the main reason that they get transplanted. But in adults, the 1-year survival after a heart transplant is 85 to 90%, and the median survival is about 11 years. Conditional survival, which means if you survive the first year, then your survival is more like 13 and a half years. So when they do a transplant, they remove the heart from the recipient, and then they anastomose all the great vessels and put the new heart in. Kind of, you can see the suture lines in the picture there. And you can see on the left a picture of a heart that's waiting for to be donated into someone. So for lung transplant, you can either have a single lung transplant or a double lung transplant. So one or both. It's utilized for end-stage lung disease, commonly due to pulmonary fibrosis or COPD or cystic fibrosis or pulmonary hypertension. So a double lung transplant, or bilateral lung transplant, we often call it, has better and longer survival than a single transplant. But a single lung transplant is not as big an operation, and sometimes it's used for older recipients or for times when the team is more desperate to get their patient a lung and only one lung gets offered, so they'll take it rather than waiting to see if 2 lungs come up down the road, and there's no guarantee that they will. So 1-year survival for lung transplants is about 80 to 85%. And their median survival is about 7 years for a double. Their conditional survival for a double is about 9.7 years. And then for a single lung transplant, median survival is about 4.5 years. So lung transplant does not offer as much kind of longevity survival-wise as heart transplant does. That said, that's the overall survival. So depending on the diagnosis leading to transplant, that can have a big effect, and this is true for hearts and lungs, on how long someone survives. So for example, in lung transplant, a patient with cystic fibrosis typically is expected to survive a good deal longer than someone who has another diagnosis, because typically patients with cystic fibrosis who require lung transplant have many fewer comorbidities, and they're a lot younger to start with. And so they tend to do better for longer after a lung transplant. So we're going to talk about pre-management for heart transplant patients. So if you see a pre-transplant patient for an evaluation, you kind of identify their baseline function. And you look at what limits do they have that we look at in physical therapy other than their cardiac status. And then you kind of address what you find. So we know that advanced stage heart failure patients can have limits to their strength, sometimes to their diaphragm strength. We look for balance or flexibility deficits, range of motion deficits, and we kind of maximize everything we can given their limited cardiac function. Now, what's kind of a game changer in the last couple of years in heart transplant is that many patients now have mechanical circulatory support devices, or MCSDs, implanted before their transplant. So that could be ECMO, that could be a VAD, a ventricular assist device, that could be an IABP, that could be an Impella, a lot of different devices out there. And depending on what device they have and what device they, and how long they've had that device, it often allows for them to have more activity tolerance. So if you have a patient who has a VAD and they've had their VAD for 6 months and they've gone home and they're living their life and they're fairly active, they might be able to be at a higher level functionally before their transplant than someone who gets a transplant who does not have a device in place and whose cardiac output is not as good. So that is an ever-changing thing right now as the technology just continues to explode. But just know that that could be a whole other talk, but you just have to look at what device your patient has and how that affects what they're able to do mobility-wise. We try to get these patients, if they're outpatients, into a cardiac rehab program if possible to keep them as conditioned as possible. And really important for all pre-transplant patients is that we as PTs really instill the idea that exercise is an important part of their daily life going forward. In order for them to be good stewards of this really precious gift they're going to get of a transplant, they need to have a healthy lifestyle afterwards. And exercise is very important, first of all, for them to make the best recovery they can, but also for them to continue to do lifelong so they can take good care of those organs and make the most of them. So we really, really talk about exercise as part of a healthy lifestyle with these patients.
I'm not tall enough, but...
Well, he was looking at Katie behind you. Don't get it.
Blood pressure looks great, Wayne.
Well, you got all the comedians with you today, Wayne. We'll have to remember to tip the wait staff.
None of them overly funny.
Right.
There we go.
Nice and easy.
That's where we go.
Let's turn left. Hold out. Katie, I'll have you get the chair.
So this is a video of one of our patients at Fredert who is on the list to get a heart transplant. And he is given permission to be in this video. So he has an LVAD, which is a left ventricular assist device. And you'll see the PT who's on the patient's left has the pack, he's carrying it. He has an RVAD, which is the big tubing coming up out of his neck that his nurse is holding, which is supporting his right ventricle. And then all of his portable monitor and the device that is the RVAD is on this wheeled cart that's in front of him. Someone's going to follow him with a wheelchair. Somebody else is going to be pushing his IV pole.
Look up, Wayne.
There you go.
Good. I know I'm not much to look at, but...
Well, he was looking at Katie behind you. Don't get it.
Blood pressure looks great, Wayne.
Well, you got all the comedians with you today, Wayne. We'll have to remember to tip the wait staff.
None of them overly funny.
Right.
There we go.
Nice and easy.
That's where we go.
Let's turn left. Hold out. Katie, I'll have you get the chair.
And we put this video in here to show you what a team it takes to keep someone who's waiting for a heart transplant kind of conditioned enough that after transplant, they'll be able to be successful. So this patient was in the hospital starting in July. This session happened in September. and then they received a heart transplant in the middle of October. They went to So for pre-transplant management for lung transplant patients. So once again, we identify their baseline function and we try to maximize their mobility given their limited ability to oxygenate. So especially in end-stage lung disease, musculoskeletal limits are really common, and proximal strength is often an issue for these patients. So we really focus on strength, and we really focus on posture, because a lot of them, as you've talked about, have postural deficits. And then we do a lot of the things that we have learned in lab in terms of breathing strategies, airway clearance, teaching energy conservation. So maybe they need to use a shower chair. Maybe we need to talk about paced breathing for doing activities of daily living. And we kind of incorporate all of that into their pre-op exercise program. A lot of times, patients with end-stage lung disease need to do intermittent or interval exercise, and we talk about their work to rest ratio and try to get it to where they're doing a little more work and a little less rest, but they often can't exercise continuously for very long. We also try to have them in a pulmonary rehab program, pre-op if possible. And once again, we really instill the idea that exercise is an important part of their life going forward. So there was a study out of Toronto. Toronto is where the first lung transplants in the world were done, and they are still a very big and very well-respected program. And this just gives you an idea of how low-level pre-lung transplants can be. So in their study, the average treadmill speed that their patients pre-lung transplant exercised at was 1.4 miles per hour. So think about how slow that is. That is exercise for some of these pre-lung transplant patients. So just think about the low-level kind of goals you need to set for these patients. They still need to do it. They still get benefits from doing it, but it's much lower level than I think we think about for a lot of our patients. The other thing that study found was that you really have to take into account their oxygen requirements when they're exercising. So their patients who needed more than 6 liters a minute to maintain their saturations were able to do less activity overall than those who needed less than 6 liters a minute. That was kind of the split for higher or lower ability to exercise. Okay, so let's talk about acute postoperative management. So we start seeing our postoperative heart and lung transplant patients in the ICU, often on post-op day number 1, and we continue to follow them throughout their hospital stay. Early mobility is really important for these patients, just like for all of our ICU patients. And these patients are very, very immunosuppressed so that they don't reject their new organ. So infection control is really important for these patients. And the big things that they monitor patients for are rejection and infection. So we watch their hemodynamic response to activity. And the goal is for them to have improved functional mobility compared to pre-transplant. So for most surgeries, people don't immediately leave the hospital and feel better and have better mobility. It takes them a while to get there. But for our heart and lung patients, it's often pretty dramatic how much better they are when they leave the hospital than when they came in. And that's really fun to see. So for heart transplants, acutely in the hospital, this surgery is typically done through a median sternotomy. And I know you guys have learned that sternal precautions vary greatly, so you'll have to see at your center what the precautions are and follow those. The length of stay for a heart transplant is typically about 7 to 10 days post-op. Important to know that their EKG may have 2 P waves because there might be a remnant of their native atrium left in their chest. So do not be alarmed if you see 2 P waves for these patients. The other really important piece for heart transplant patients is that their transplanted heart is denervated. So what that means is their resting heart rate will typically be between 90 and 110 beats per minute because their rate is controlled intrinsically by their SA node. Okay, there's no autonomic nervous system to speed up or slow down their heart rate. So the only way their cardiac output increases is as a result of preload, so more blood coming back as they start to exercise, and circulating catecholamines. So when we start to exercise, our brain tells our heart to start pumping harder and faster in anticipation of what we're going to do. That does not happen in these patients. They don't have sort of the fight or flight response. If you're driving along and someone brakes hard in front of you and you have to slam on your brakes to avoid rear-ending them, and all of a sudden your heart rate has jumped up into the 150s and it's just beating in your chest, that doesn't happen to these patients. They don't have that innervation. Their brain does not tell their heart all of a sudden something's going on. So we have to be really good about warming up slowly and cooling down slowly so that their heart has a chance to catch up. Because if we try to exercise or change position too fast, their heart won't be able to keep up. It also means their peak heart rate will be lower than non-transplanted individuals. Okay, so for lung transplant patients. So lung transplant surgeries are done in a variety of ways. The most common is the clamshell surgery for bilateral lung transplant, which goes straight across the chest and cuts through the sternum, usually at the 5th or 4th interspace, and then they just open them up like a clamshell. It also can be done via a thoracotomy if it's a single transplant, or a median sternotomy is the other way that some surgeons prefer to do them. So the length of stay post-lung transplant is typically more like 14 to 18 days. And we really work with these patients early on airway clearance. So we've learned a lot of airway clearance devices and techniques. So we work on incentive spirometry, we work on their cough, we work on acapellas, PEP devices, whatever they need to help clear out those new lungs. Similar to hearts, the transplanted lungs are denervated. So these patients do not get the irritated sensation that they need to cough that we get. So that leads to the cough being less effective and a decreased sensation of the need to cough. So we have to teach them that they have to cough even when they don't feel like they have to cough, because there will be stuff in there that needs to get cleared out after this big operation. And then we often have to teach them a normal breathing pattern. So if we think about all of the upper chest kind of ineffective breathing patterns that a lot of end-stage lung patients use, they don't need to do that anymore. They don't need to use their accessories anymore because they have a new set of lungs that's going to work really well for them. So they need to relearn diaphragmatic breathing if they can. They need to work on lateral costal expansion to get their lower ribs to kind of expand. Kind of fix that upper chest pattern, emphasize posture with them, because their body will naturally go to the pattern it had been using for many years probably that's not as effective now. And then for lung transplant patients, proximal weakness is really a limiting factor for their activity. And the research tells us that we have to target peripheral muscle strength in order to improve their function. So these patients' lungs will give their muscles all the oxygen they need now, the new lungs. But I tell my patients all the time, you got a lung transplant, you didn't get a leg transplant. So when they complain about feeling tired, feeling like their legs are like jello, they're not getting short of breath anymore when they walk around, but their legs fatigue fast because their legs were at a low level to start with and they need time to get built up. And they've been through a big surgery, and now they're on high-dose steroids, which we'll talk about in a minute. So lots of reasons that we really have to target their leg strength to get their function better. Okay, so moving into the outpatient phase. So for post-heart transplant patients in outpatient rehab, it looks a lot like phase 2 cardiac rehab. You want to monitor their vitals, and their RPE is really important because remember that their heart is still going to be denervated. So we can't use heart rate by itself as the monitor of their intensity. So we really want to watch their RPE. These patients also, because they're denervated, do not experience angina like non-transplanted individuals. So we can't rely on that as a chest pain as an indicator of ischemia like you could in patients who do not have a transplant. And again, we want to warm up and cool down slowly so that we allow their heart rates to come up and down in the appropriate way. So we're going to address aerobic training and strengthening in the outpatient post-heart transplant patients. So you find the mode that works for them. It could be the treadmill, it could be the new step, whatever kind of is good for your patient. We really work on strengthening to combat the effects of the corticosteroids that they're on. Upper extremity resistance training will depend on your center's precautions and kind of MD preference. And then we monitor them for signs of rejection. And we will talk more about that later. This is just a summary of kind of the guidelines I just said. Okay, so for post-transplant outpatient lung transplant patients. So their post-transplant recovery looks a lot like an outpatient pulmonary rehab program, 2 or 3 times a week. Again, we're watching their vitals and their RPE. So the saturation guidelines will be set by the physician, but generally, if they didn't have any complications, these patients should saturate normally and be off oxygen. So they really shouldn't desaturate with new lungs that are working well. But depending on what may have happened postoperatively, we may have to follow some guidelines. These patients will generally be lower level to start with than the heart patients will. So their goal is to get to 30 minutes of continuous aerobic activity. Remembering that pre-lung transplant, they needed to do intermittent exercise, and sometimes they could work for a minute and then have to rest for 2 minutes. Okay, so we're starting off low level here. So we can use normal vital monitoring for these patients. We can try for 60 to 70% of their heart rate max, an RPE of 13 to 14. We again find a mode that works for them. And then we really work hard at muscle strengthening, because the limiting factor for these patients, again, is frequently their muscle strength and endurance. Again, we have to wait for upper extremity resistance training until we get physician okay for that. We address a lot of posture deviations and upper extremity movement patterns. A lot of these patients have limited shoulder range of motion and a lot of rounded shoulders, forward head posture from years of kind of tripod posturing to try to improve their use of their accessories so they could breathe better. And again, we look for signs of rejection. So rejection means that the recipient's body is attacking the new heart or the new lungs because it perceives it as foreign. And in the first year after transplant, 25 to 30% of heart and lung patients will have an episode of rejection. So they need to have a biopsy to confirm that. And then the rejection gets graded based on how severe it is. And depending on how severe it is, they either get outpatient treatment or they have to be admitted to the hospital for their rejection. So typically they will have their steroids increased if they have an episode of rejection. And we know that increasing your dose of steroids leads to more weakness. And their other immunosuppressants will often be increased as well. So we need to talk to patients when we're seeing them in the outpatient setting about learning to recognize early rejection, okay? Because we're the people, once they get to the outpatient phase, who see them 2 or 3 times a week, who have a lot more eyes on them and a lot more interaction with them for a longer period of time. So lots of education for these patients. So signs of rejection for a patient who's had a heart transplant are flu-like symptoms, a low-grade fever, muscle aches, kind of not feeling well overall, and then you see dysrhythmias, relative bradycardia, and blood pressure changes. So if your heart transplant patient comes to cardiac rehab and is like, yeah, I just don't feel very well today, and when you put the monitor on them, their heart rate is 20 beats a minute lower than it usually is at rest, that should raise a red flag for you, okay? For lung transplant, signs of rejection are shortness of breath, fatigue, desaturation either at rest or with activity. So if your lung transplant patient is having more trouble walking on the treadmill and they're desaturating and they do not desaturate with you normally, and they're telling you they feel more short of breath, you can't just say, oh, they're probably more tired today. That should raise a red flag. And anytime you suspect they might have rejection, you need to report that however your system reports that, to the transplant coordinator or to the physician. Because repeated episodes of rejection, especially untreated, can damage the organ permanently. So we want to be sure that any early rejection gets checked out by the physician team and not ignored. So we're going to talk just a little bit about medications that patients are on following a transplant. So in order for the heart and the lungs to work properly, the patients have to be immunosuppressed so that they don't reject the organs. And this is true for the rest of their lives. And it is not uncommon for heart and lung transplant patients to be on 10 or more medications every day at various times of the day. They have a really complex medical regimen, and there are lots of frequent adjustments that are needed. And there are a lot of side effects to transplant medications. We have to always remind our heart and lung patients that transplant is a treatment for their disease, but it's not a cure, and it brings with it, unfortunately, a lot of other side effects to treatment. So this box is busy, and you don't have to know all of these things, but what I want you to know is that the first line at the top, the anti-lymphocyte antibodies, are anti-rejection medications that are just given in the hospital for someone who has a severe rejection episode. And if they're hospitalized for rejection and they're getting something like OKT3, which is the one I happen to see a lot, it's just the trade name, it can cause unstable vital signs, and these patients are not exercising, and we are not seeing them for therapy until that gets more under control. So then the next three lines, typically patients are on some 3-drug combination for anti-rejection, okay? And it's usually one from each of the classes. 1 anti-metabolite, 1 corticosteroid, 1 calcineurin inhibitor. So you can see that there are a lot of adverse or side effects that come with these drugs. So these drugs, by design, are suppressing the immune system. So these patients are much higher risk of infection. So we need to be very careful with infection control with them. One of the other common side effects is osteoporosis, okay, specifically from the prednisone. And so we want to be sure that for any transplant patient, and I would say any organ transplant patient, not just heart and lung, if you see them in the outpatient setting, like maybe they come to you because they have a knee replacement and they have a history of a kidney transplant, we should treat these patients as if they have osteoporosis unless we know otherwise, because it's very common when they're on steroids for a long time. These medications can give them some CNS issues. So prednisone is notorious at high doses for giving people insomnia and for giving people kind of psychiatric personality type troubles, which hopefully get better as their doses get weaned. Most transplant patients in heart and lung, initially at least, will have problems with glucose control and will become diabetic, at least temporarily. One of the signs to look for in your outpatients is if they have a new tremor, because tremor is a kind of hallmark sign of your level of your calcineurin inhibitors being too high. So patients who have tremor might have a toxic level of Prographer or something like that, and that's something you would report to the team as well. And the other thing is that these drugs are very tough on the kidneys. So about 25% of patients after heart and lung transplant 1 year later will have some amount of renal dysfunction because these medications just are tough on the kidneys. So long term, there are complications that can occur later on in patients. So for heart transplant, they can get what's called cardiac allograft vasculopathy. So it's a really accelerated form of coronary artery disease that happens, over the course of a few years instead of over the 40 or 50 years that it happens. They get CAD in non-transplant patients. And it might be related to repeated episodes of rejection, but it's kind of this diffuse, patchy intimal hyperplasia. It's not really lipid deposits like you think about CAD being. Sometimes you can treat it with stents or cabbages. In lung transplant patients, bronchiolitis obliterans is the big long-term complication. So this is seen by repeated episodes of rejection or chronic rejection. And what it does is it damages the lung tissue itself. So it results in them being back to kind of what they were pre-transplant, which is decreased lung function, dyspnea with activity. And because the tissue itself is damaged, there's usually not a lot they can do about it, unfortunately. So that's why we really want to stay on top of making sure that these patients don't have any signs of rejection. The other thing to think about is that this medication regimen affects a lot of their body systems. And we've talked about this somewhat already, but patients following transplant, and this is true of a lot of organ transplants, not just heart and lung, are at risk, higher risk of infection. So we need to be careful about that. They're at higher risk of getting cancers because we've suppressed their immune system, a number of different types of cancers. A lot of them have steroid myopathy with weakness. We already talked about how tough they are on their kidneys and on their glucose regulation. And then high-dose steroids lead to decreased wound healing, as we all know, as well. So just kind of keep in mind that there are lots of other systems we have to think about when we're treating heart and lung transplant patients. So I can't end on a sad note here because there is so much good that comes out of heart and lung transplant. And these patients have a really good survival benefit and much improved quality of life after transplant. And they are just such a fun group to work with. There are lots of exciting things happening in this field right now. So the number and types of devices for mechanical circulatory support for the heart are just exploding. And throughout your careers, I think there are going to be more and more mechanical devices coming along that will provide better and better support. And I think the goal is eventually take over the role of a heart so that there's a completely mechanical device at some point that can do that without making patients have all these anti-rejection medications for the rest of their life. The other really exciting thing is what's called ex vivo organ perfusion. The picture here, you can probably get this link to work when you're not in my recording, I hope. But this is a machine that oxygenates the lungs while they're outside of the body. So a donated set of lungs can be oxygenated and can survive a lot longer before they are transplanted into someone. So that really increases kind of the radius from which someone can have lungs donated to them. And it increases the likelihood that a pair of donated lungs will be accepted for transplant because they can put them on this machine and make sure they seem like they're working okay before they transplant them into someone. So they actually breathe on this machine. It's really kind of cool. So physical therapists are such an important part of the transplant team, and I hope you guys get to work with some of these patients at some point, either because they're coming to you primarily for the transplant or because they're out in the community coming to you for something else, and this will give you some background to think about what are the important things to think about specific to their diagnosis. So I know I'm not there to answer any questions. Please feel free to reach out if I see you guys in lab after you listen to this, or via email to Dr. Luke or to myself. I'm happy to answer any questions about the transplant process. So thanks for your attention, and good luck. Patient rehab only 3 weeks later, and then they went home only 2 weeks after that. So I would argue that the fact that they were mobile for those several months while they were waiting for their heart transplant really made a difference for their post-op course and their ability to go home. So I want you just to kind of watch and see the village it takes. Okay, so as you can see, this patient didn't walk that far, but keeping him mobile was so important to his outcomes later. And I think that's a really exciting thing that we can offer to people, is to maximize their functional mobility while they're waiting for their new organ.